Welcome back to everyone in our audience. It's great to have you again. I'm extremely excited for this panel presentation that will be led by Dr. Christopher Longhurst from UCSD Health and includes leaders from UCSD Health, and Scripps Health in San Diego. Dr. Longhurst is going to run this entire session. I will just appear again at the very end to conclude. So, batting it over to you, Dr. Longhurst. Good luck, Godspeed, and enjoy.
Thanks so much, Mark. Well, I'm really excited to be here with everybody today for this virtual session on virtual care. So we're talking today about innovation and digital health, and there's a lot moving, as we know. COVID has been a real catalyzer for a number of different initiatives in this space, and people are beginning to ask themselves, how do we move beyond simple FaceTime for telehealth to things like remote patient monitoring and digital therapeutics that impact the care of the patients that we see, as well as the patient and staff experience. So I'm excited to introduce our panel today. We've got two members from UC San Diego Health, Jeff Pan and Nicole May, who are joining us to talk about the new UC San Diego Center for Health Innovation and some of the projects in that portfolio. In addition, we also have Katie and Dr. Lajay Ajayi, who are joining us to talk from Scripps Health about their digital health team efforts as well. And as usual, we're always excited to not only collaborate, but learn from our occasional competition. So this is a fun panel and look forward to this. With that, I'm going to hand this over first to the UC San Diego Health team, and then to the Scripps Research team, who will talk about efforts at Scripps Research. And then we'll wrap up with some Q&A from the audience. So Nicole and Jeff, please take it away.
Hi, I'm Nicole May, and I'm really excited to be here today and describe for you with Jeff the Center for Health Innovation here at UC San Diego Health. This is a brand new center, and one second. It's a brand new center, and really the first of its kind here at UC San Diego Health, in that it's the only center that's fully embedded in the health system. And the idea here was that pulling a center for innovation into the health system would really catalyze all of the innovation that's going around on our our campus, which is known for its engineering, its computer science, its discovery, and bridging really all the things that are happening that are so exciting on campus with all the exciting things that are happening in the health system. We've always been innovating, but we're really trying to use this center as, again, a catalyst or a hub or a bridge to bring all of that together for the benefit of our patients. What we learned during COVID is that we're innovating a lot and on the fly. And if we could do this in a more kind of organized or methodical way, we could probably do this in a way that we could achieve it faster and at scale. And so that is what we're really looking at doing. And you can see that we have this ecosystem of partners that we're bringing together, and we're really excited. So I'm going to turn it over to Jeff to talk about a couple of our new projects.
Thanks, Nicole. So our first project here, we're naming Project 1000, which is a project in the digital health space, specifically remote patient monitoring. This takes our existing work of hypertension and diabetes care and adds an element of home-based care so that we can continue to monitor how the patients are doing while they're at home in a real-time, fully EHR integrated manner where patients enjoy the benefit of active management of their conditions. COVID clearly created the conditions that made it difficult for patients to come in. Telehealth really would fill that gap, but that still resulted in a depressed state of engagement with the healthcare system. We took this as an opportunity to develop a pipeline that would be device agnostic, that would care not just for COVID or for the most acute conditions, but would be a starting point for a full spectrum of connected care with our patients. Project 1000 specifically aims to study this exact pipeline we've created and take a people-centered approach to better understand what is the actual experience of patients on the other end of these devices. How do they interact with it? How does their larger family and connected health bubble interact with them as well? If we can engage patients in their home with these devices, we can actually make meaningful changes without the patient ever needing to sit in traffic to come to a physical setting for routine care, and really have them come in for only the times we need a true physical exam or they're more acute cases. So this is an exciting program for us to really study and develop new technologies with industry, with researchers, and really take a deeper look at our services that we provide and combine them all together to design the future of connected care. The next project space that we have is in data science. Data science in healthcare is exploding right now. There's so much data that's available and so much research that's going into developing the latest models and algorithms that can predict outcomes that are just humanly impossible to consistently fathom on a regular basis. And so in the data science space, what we're looking to do is identify these gems of models that really are high performing and provide a lot of value, and determine how we can make them accessible and scalable at the point of care when patients are actually working are face-to-face with our providers. And so what we are doing right now is investing in the technology and the platforms to start with connecting data science algorithms in real-time clinical decision support moments, and actually measure the efficacy of this and how it affects the patient's decisions on how they utilize healthcare, how it affects the providers and how they place orders and treat the patients, as well as look at the larger effects of this in the environment and the community. As we work in this space, we look to the future as well as how we can connect these models directly to the patient so that we can be modifying their behaviors and giving them the information they need to self-manage their care as well. This is an exciting space to be in because the future between the two of them, digital health and data science, really are related and destined to be together. When we look at the future of the space, when we take the data that's collected through all these devices, combined with very powerful models that can compute this, it really tees us up for a population health management solution in the very near future, where we can really have our fingers on the pulse of the entire community. Cool, I'll pass it to you.
You're muted, Nicole.
Thank you. Yeah, so the last project we wanted to discuss today, which really rounds out our first year portfolio, is CA Notify. So a year ago, actually a little more than a year ago, we were approached by Apple and Google and the state of California at UCSD to pilot exposure notification mobile technology. This was the first pilot of the ENX, which is Exposure Notification Express system that Apple and Google developed to try to rapidly get these into the hands of the community. And as part of our Return to Learn program to bring students back to the UCSD campus, we launched this, and it was very successful. We estimated that 50% of our campus actually turned this on. Because of that success, we then tweaked the technology and worked on some human factors designed to make it not only more robust, but more adaptable and adoptable. And then went live with this at sister campuses across the UC. That was in November, right before Thanksgiving, and the pandemic was heating up. And the governor's office looked at the success of the UC pilot and said, you know what, we should go live with this. We're heading into the Christmas holidays, and we really, really need this program to work. So we've partnered with the California Department of Public Health to then implement this to the entire state of California. And you can see our activations today of the system are over 13 million. We've sent out over 100,000 exposure notifications and alerted 300,000 people that they might have been exposed. We're still doing the scientific analysis, but we believe that thousands of cases of COVID had been avoided, and probably dozens to hundreds of deaths avoided as well. So this was our first innovation project in this portfolio that bridged some of our campus engineers locally with our health system and the California Department of Public Health, and even some partners in Canada that we continue to work with. We're enormously proud of this, and Excited that innovation touched the pandemic in this way and made such an impact. So that's our portfolio here at UC San Diego Health. And we'll turn it over to our Scripps colleagues to discuss their innovation program.
Chris, I think you're on mute.
Thank you very much, Nicole and Jeff. I know there'll be a lot of questions on these topics. And with that, we'll switch over from the UC San Diego Health efforts in this space to the Scripps Research efforts. So again, really excited to introduce Katie and Dr. Lajay Ajayi, and looking forward to what you both have to share from Scripps Research efforts around digital health.
Wonderful. Thanks, Chris. I'll start. So I'm Katie Bakamotes from Scripps Research, our Digital Trials Center. Super excited to be here along with you, Chris, and our UCSD partners. We want to talk a little bit about the innovation that we're doing. Another center, this one across the street, catty corner to the UCSD campus. And what we've done recently is we've taken all of our direct to participant in digital research trials and put it under one umbrella, the Digital Trials Center at Scripps Research. This has been, oh, it's not going to let me change my slides. So give me just 1 second. We had to have some technical difficulties today, so let's see. Nope, it's not going to let me do it. There we go. So what this is a digital trial center sort of years in the making. So for those of you who don't know, Scripps Research, we are led by Dr. Eric Topol, who has been doing work in digital health for many decades now. I think we'll start with just highlighting a couple of our past research efforts. One of them was the mSToPS randomized trial. I'll point that one out because that was the first one that brought me to the team to work with Eric and Steve and others on that program. It was one of the very first where we did direct to participant outreach, recruitment, and study design that was really meant to be direct to participant and engage with people with the digital health technologies. And I'll point this out because it was a population, I think our average participant was age 74. So in addition to being new and innovative, we were showing that we could do it on a population where, you know, maybe the digital health technology wasn't as easy as some of the younger populations. The other is the All of Us Research Program. So our group led the Participant Center for the All of Us Research Program for many years. And that's really kind of what started the Digital Trial Center as it exists right now. So back in 2015, when the All of Us Research Program was announced and we received the grant, part of our initiative was to incorporate digital health technologies into the program, but also serve as the direct volunteer arm. So as Nicole mentioned, there's lots of great innovative work being done within academic medical centers. Our group was really meant to complement that and be able to go directly to any participant anywhere that wanted to raise their hand and be a part of this program. So that means we had to figure out a way to get to every single person living in the United States and its territories to do the complete protocol. That's from answering survey questions to collecting biosamples in a convenient location or even in the home, connecting electronic health records, regardless of what health system you were a part of, and connecting wearable device data. So once we started doing that and building this infrastructure, we did so with a number of partners. This is just a sample of some of our partners. I think we have about 37 partners that we work with across the United States that helps us build this infrastructure. And really, so we started to think about scalability. So if we can build this for one massive, wonderful program, can we take elements of those? Can we modularize it and start to build this foundation for democratizing research? And this is, we needed to do it across all of these things, across, you know, we had to learn more about data sharing with all of our different partners, data sharing back to our participants to really provide value for them. We needed to improve the participant experience. We needed to look at new technologies, and we really needed to make this scalable. Again, it's got to be easy and it's got to be accessible anywhere in the country. So with that, we brought together, and this is just a snapshot of some of our wonderful folks that we work with here at Scripps. Our team is about 40 folks, but we have expertise across, clinicians, we have experts in machine learning and AI, we have pediatricians, we have neuroscientists, and then you have folks like me. I'm a applied behavioral scientist, so I'm always thinking about the participant experience and incentives and motivation and decreasing barriers. So we have expertise across the spectrum that we think is really important and a differentiator for us as we think about the end-to-end participant experience. So all of that sits under the Digital Trials Center. Right now, this year, we're focused on 6 different domains here. Infectious disease is one of them. I'll highlight that quickly because it was our sort of proof of concept of how we take the infrastructure that we had and how it can enable other research. At the beginning of the pandemic, we had just published, our group, Dr. Radin and Dr. Quare had just published some work looking at wearable device data and its ability to detect flu outbreaks early. So at the beginning of the pandemic, we wondered if we could do the same thing for COVID. We brought together our technology partners, our outreach partners, our wearable device partners, and we went from concept to national study launch, I believe in about 4 weeks, and enrolled 40,000 people in the first 4 months as a part of our Detect study program. So it's a great proof of concept for us. I'll say 4 weeks, it was a lot of work. It was not a regular work week. It was many, many hours, but it did show us the possibility of doing this. And we've extended this out into sleep medicine, precision nutrition with a focus on type 2 diabetics, and then heart health. And then I'm going to turn it over to Lachey to talk about our maternal health, Power Mom, Healthy Pregnancy Research Community, which is near and dear to our heart, is our next very much passion project. Lots of blood, sweat, and tears on this one too. And Lachey, I'll turn it over to you.
Thank you so much. Thank you, Katie. So again, my name is Lachey. I'm one of the clinical researchers on the Digital Trial Center, and I am a pediatrician. And honestly, looking, and more importantly, I'm a mom of 2 beautiful children. Power Mom was a study that we actually launched back in 2017. I'll talk more about what that pilot looked at in 2017, but really it's a research platform that leverages EHR connectivity, wireless devices, different third-party apps to really create the largest database of pregnancy information. And the reason being that we know that pregnancy, when you're pregnant, it's hard to participate in research. So how do we actually meet the participants where they are and build them into this nice virtual community where they can actually feel like they're partners in the research that they're contributing to? We can go to the next slide, Katie. So back in 2017, in a very bare bones platform, we thought, what would happen if we just embedded our Power Mom application into the WebMD pregnancy app and see who'd be interested. And so no direct outreach, no recruitment or anything like that, and just ask people to provide information along their pregnancy, just some survey questions. And they happen to have either a Fitbit or an Apple Watch. They could connect their device if they choose. And so within about 9 months, we actually had over 3,000, over 3,500 participants enroll in the study. We had over 14 different types of data points that really lended information to actually provide a clear picture of what a healthy pregnancy looks like for different populations. And we learned from that. Again, without any direct recruitment, our pregnancy population was more diverse than the US in particular. And so when I became principal investigator for Power Mom, I realized this is actually a great tool to study and actually reduce health disparities in maternal fetal health. So this platform, we know that it works. We know that people are willing to provide their data because they choose what they get to provide. And now with our relaunch, they can actually see the information that they're contributing. So they truly feel like they're partners. And then as we get a critical mass of data points and people enrolled in this new platform, we actually use the application to return information back to the participants. So they don't have to wait for those pesky journal articles. They actually, again, are partners and they get to see the information we provide to them. Also, because it's a kind of an open source database, we can partner with our colleagues at UCSD or their researchers who want to look at these data points to be collected, really drill down and actually ask specific questions. We can go to the next slide.
Try, Moshe. I'm sorry, I'm having some technical difficulties here.
No worries, no
In
worries.
San Diego, so nothing works.
At least we're not up north where they had that huge deluge of rain and they had no power. So I think we're doing pretty good here. But the point of Power Mom is really to have this research platform that's flexible and nimble enough to do different types of sub-studies. So for example, we can work with other researchers who want to look at gestational diabetes and maybe look at continuous glucose monitoring in this population. Dexcom has provided in-kind donations for us to actually use this platform to take a deeper look into glucose, continuous glucose monitoring. We, through a partnership with Fitbit, who's one of our partners in this particular sub-study, we can actually look at the influence or the effect of structural racism throughout a patient's pregnancy journey. So again, as Katie said with the DTC, we built it, right? And then we scale it national. So we're not limited to pregnant people in California. We can do this at a national level. We know that lots of pregnant people have smartphones, are able to access the application itself. The database, the access to data is a little bit difficult, but most people actually are able to run. It's a low yield platform that can easily access on Apple or Android. And from this platform, we can spin off. Another partner we have is looking at postpartum depression. So we can launch different sub-studies and actually get more information about pregnancy, fill in those missing gaps that we don't have about what makes a healthy pregnancy for everybody, and really build this community, research community with hopefully 1,000 and more pregnant people. And with that, Chris, I think we can turn it over to you for any audience questions we may have.
Okay, well, thank you very much, Dr. Ajayi and Katie. Really interesting to see some of the similarities and differences. I think a lot of commonalities around the strong history of innovation, and with, I think in particular, looking at outcomes, right? This is something that we know some of the startup culture occasionally misses, is the promise of these digital health tools and applications without really demonstrated outcomes. And so I admire both teams in the commitment to really ensuring that these therapeutics or interventions are actually having the impact that we hope. Nicole, you mentioned the CA Notify impact on exposures and infections across the state. Dr. Ajayi, you mentioned the Power Mom study and the potential impact there as well. So with that, I'll kick off our first audience question. Dr. Ajayi, this one's for you. What complexities did you overcome in scaling up the platform to facilitate pregnant people's research platform?
Absolutely. So I think the biggest obstacle they overcame is how do we reach on a national level the participants we're looking for to enroll in the study? And Katie can weigh in more because she was very keen into that. So it was really, how do we have these, how do we work with our national partners to get pregnant people involved in this research study? And that's been the biggest challenges. So working with both local and national partners, for example, Philips, Fitbit, some of the different national partners we have to then spread the word, because the power in Power Mom is in the participants that they use it. So to scale nationally, it's moving beyond California, moving beyond San Diego to a national level.
That's great. And Lajee, I think one of the exciting things that all of us involved in these tools enjoy is the potential to impact so many patients at a population level, far beyond, you know, what we can touch as pediatricians, since there's two of us here. Nicole, you mentioned some of the outcomes on the exposure notification system. And I know that you're partnered with California Department of Public Health and California Department of Technology to really scale across the entire state. Can you share with the audience some lessons learned around those partnerships, you know, with our public health colleagues and government, as well as our industry partners?
Definitely. I would first say kudos to the California state government, CDPH and CDT, because they took a risk. We were the first pilot in the nation to go live on this technology, and they knew they needed it for the pandemic. Apple and Google had just developed it. They were looking at a third-party app, but ultimately they chose this technology because they knew it would be fast and scalable, and it would meet the needs of the pandemic. And so they've been all along the way excellent to work with. We piloted some things with CDPH and CDT that hadn't been done before either. For example, we started sending out codes via text message. And what happened there is that other states had actually put the code usage for this tool in the contact tracer's hands. Well, this is digital contact tracing and you want it to go faster. By getting the codes out earlier, people were notified that they were exposed within 2 or 3 days versus 7 days. And so working with these partners has been awesome. It's been less challenging than you'd think working with the government because of the pandemic. And so everyone was really motivated. Things went fast. Decision making was fast. And it was a very forward thinking group. So it's been nothing but positive.
Terrific. Well, I'm sure your collaborative style helps with that, Nicole. So thank you very much. Katie, question here from one of our audience members. What are the biggest challenges of bringing together such a large and diverse constellation of experts, leaders, and other participants into these projects and initiatives?
Yeah, I think for us, all of our studies are really built around collaboration and a consortium. So you really have to bring people in from the beginning and make it feel like that's their own. And so that's everybody from, the other experts in the room, the industry partners, the health system partners, and then the participants as advisors. So we have a great virtual advisory team of participants that we bring in, and it's interesting to see just how the dynamic changes when they're in the rooms and they're coming in to plan along with steering committee members and others. And it really kind of sets the stage and makes sure that everybody's being collaborative, because I think that the end, the impact is always there. And the reason why we're doing the things that we're doing is clear and present. So that's something that I think helps us as we bring in all of these different industry players, because like I said, even our team, a group of 40, we can't manage, $1 million person cohorts on our own. We really need those partnerships to continue to grow and develop.
Yeah, that's helpful, Katie. Thank you. Another question that came in from the audience, Jeff, is from Mark, who asks about algorithms. So what are the challenges in developing useful algorithms to facilitate some of this advanced and adaptive clinical decision support? Are they process, clinical, technical, ethical, or other?
I would say it's ethical. When it comes down to the other domains like process or clinical or technology, I think the technology is there. Groups like the FDA have laid out clear processes on how we handle things like evaluating clinical association, analytical validation, clinical validation. But once we get to the ethical space of things get far less defined in this space. When we look at some challenges like how do we ensure that the models that we put in place are transparent to the provider as well as the patient, and they understand that what factors are being used to direct their decisions or the course of their care. How do we ensure that the models that we're training and developing maintain a level of fairness and are not inherently discriminatory, or it includes biases in how they're trained? And how do we ensure, especially with models that are so data rich, that we are paying respect to the privacy and security of the data that the model is using, as well as that it is outputting? And so these types of considerations in the ethical space really challenge us to examine the values that we imbue in the program and in the models, and a really challenge to ensure that there is a common benefit to all patients that are run through the model.
These are critical, and it's obviously a conversation occurring nationally. Jeff, I'm going to ask you a follow-up question on this topic too, which is, as you look at things like sepsis prediction, do you think that the data in our EHR will be adequate for actionable real-time decisions, or do you think we'll need to integrate additional data sources?
There's certainly a lot of data within EHRs to get us through, I would say, the next year or two, maybe even 3 years of further development of AI models. But when I look at the future of AI beyond just at the point of care for clinical decision support, but really looking at how we take these models and assess the whole entire health of a population, especially in the climate of value-based care, other information is going to be critical to really assess the impact to the general population when it comes to the cost of care, their social determinants of health, as well as how their health affects other domains in their life that are outside of the patient's interactions with the healthcare system. And so I think currently there's a lot of untapped potential, a lot of overhead with the data in the EHR, but to maintain the current trajectory and pace of innovation, groups will definitely need to be looking at genomic and community and social media and financial domains of data to really leverage the full potential in the near future.
Well, thanks, Jeff. Nicole, I'm going to ask you a follow-up question because Dr. Ajayi mentioned design thinking, and I'm interested to hear how you're thinking about design thinking from a digital health standpoint.
Yeah, it is central to the way that we're looking at digital health, actually. The idea being that we can have all the technology in the world and we can put it out to our patients, but if they don't use it, it's doing no benefit. And design thinking, we call it healthcare human factors, is something that's integral to what we're trying to do with digital health. And I think that's what we think is going to make the difference in having a few devices out there that a few people use to having most of our population using devices to manage their care. The idea is that we would like to have patients to feel like they're having a perfect day. The technology is helping, but it's not really even there. They don't know that it's working for them. They don't need to know all the details. We're thinking about this in terms of frictionless experiences and experiences with digital technologies that bring joy, right? And so we're looking at everything through a usability, human factors lens, doing a lot of ethnographic research and design thinking up front before we even launch our programs. And this not only will help our patients, but it'll help us scale for our providers as well.
Great point. Katie, do you have a follow-up comment on this one around participant experience?
Yeah, I love what you just said, Nicole, on the bringing joy to participants. So as I mentioned, I'm an applied behavioral scientist. So Eric and Steve kind of plucked me from doing research at Disney. When I tell my teams, I'm like, how are we bringing the magic, right? How is this a magical experience? Because I think so often researchers, we want to just take. So I think part of the way that we design our programs is every time you ask for something, you are giving something back. Now, that can be gratitude, it can be information, it can be automatic feedback on your continuous glucose monitor, whatever it might be. But I think that design thinking that you guys are doing, we very much, try and embed that in every single one of our experiences. And some of it's a little scary, how do we start to, give the electronic health records back to individuals? How do we start to give back polygenic risk scores? And some of it's new and novel. So there's a lot of things that need to be done. The other part that we really try and do in all of our things is understand that we're not going to get it right. Maybe the first time out, that we need to do things like A/B testing within the process, which was a new thing for the IRB. It's like, what? You want to test that within the study, and you want to have two versions of a consent process, two versions of return of information. And these are new and novel things that maybe shouldn't be considered novel, but certainly are. And so there's a long, history of conversations that you have within the different IRB and the different stakeholders of the process.
Yeah, you just made some really great points. So this concept of A/B testing, I think is one that's going to come up increasingly as we think about true learning healthcare systems, right? And in fact, it was something that Nicole and her team helped to actualize for the exposure notification system when we were first piloting it here in San Diego. And so we just published a paper on this in Learning Health Systems about how we did A/B testing using different SMS alerts to our patient population. It was the first time that UC San Diego Health had ever sent messages to 250,000 of our patients locally. And so before we did that, we found 15,000 of those patients randomly and split sort of different messages to each group. And because of that, we were able to learn, I think, Nicole, in a 24 or 48 hour period, which messages, the Empower SMS versus the Slow to Spread SMS, were best responded to, and then scale that message for the further pilot. There's actually been discussion about this type of A/B testing. Number one, being a really key concept from a quality improvement standpoint. We know that marketing does this in industries constantly. We know that Google and Facebook and tech industries are constantly A/B testing us as individuals. And that's not necessarily a consent-based process. So our IRBs, as you suggested, Katie, really are going to have to think a little bit differently about this.
Yeah, that was a great paper. And it makes such a difference when you're talking about scale. So when we have partners and emails go out to millions of people, tens of millions of people, if you can, test your subject line or your email or your notification early, it makes a huge difference down the road.
The other thing we did, I think this is very important for, equity as well, and diversity, and making sure that the technologies work for everybody. When we did a whole nother round of A/B testing and focus grouping with different populations, different languages, and we found some of the messages did not translate or make sense, and didn't have the same impact to motivate folks to use the systems as they did in English. So it's just another critical factor to make sure that we're covering all of the patients and making sure that they have the same level of care and the same access to these technologies that everyone has.
We did the same thing with Palomar platform, actually. So Palomar is a largely survey-based. And even though we work with a cadre of OBGYNs who went through standardized forms that we got the questions from, knowing how they translated to English or from English to Spanish was huge for us, and even how we asked certain questions. So that A/B testing is a huge component. And I'm glad you brought up the equity issue, because I actually think the studies the work that we are doing at UCSD and at Scripps Research, again, breaks down those barriers. It makes it more accessible to people who ordinarily wouldn't, right? Not everybody can take off time from work to go and participate in research. Not everybody has the means to do that. And so I think the work that we're doing, actually by its nature, moving to a digital platform, really breaks down those barriers, and it's huge. It's a huge component.
Yeah, I agree with you. I want to give a shout out to some of our colleagues at NYU in New York. They actually published this New England Journal article a couple of years ago about creating a learning health system through rapid cycle randomized testing. And one of the things I really liked about this is that they actually published in here how they went about doing some of this, and examples of where they did it in different parts of their health system. So there's this table, which I've now made upside down, where they talk about the target outcome. And for example, their influenza vaccination alert, they A/B tested and actually wrote a whole nother paper about this in the Journal of Medical Internet Research, about how they saw a significant difference of the alternative best practice alert versus the original alert, and therefore were able to actualize that at a higher rate. And then similarly, you can see they've been doing readmissions and acute care and annual wellness randomization. But as you mentioned, Katie, one of the potential challenges to that is the IRB looking at it and saying, well, that's really clinical research, and you need to, consent each individual involved, which can become a barrier for that rapid cycle learning. Of course, we don't want to compromise any ethical principles, but I do think we need to re-examine that in light of the concept of a learning health system. All right, well, I know that we're coming up on time here. Are there any other final closing comments that anybody would like to make? Mark, I think we have a shy group. Would you like to take the closing comments?
You're all too shy and humble. That is my determination. What you're all doing, both teams, is really remarkable. I have not heard of anything quite like this. I know, Dr. Longhurst, you referenced NYU doing something similar, but this is really quite leading edge. We're thrilled to have you here. I hope that everything that you're doing bears great fruit in the coming years, because this is where healthcare has to go. It has to be totally analytics driven. I love that you have this wonderful mix of clinicians, behavioral scientists, leaders from every discipline. This is how it gets done in healthcare, right? So I just want to thank you all for gracing us with your time and your expertise today. I'm very excited by this. This is really something very special. I hope our having you on today furthers the cause a little bit by a few people hearing about it. And I just want to wish you all the best. So Dr. Longhurst, Dr. Ajayi, Katie, Nicole, Jeff, and all your colleagues. I know there's an there are two armies of people behind you here. I want to congratulate you all on your achievement so far and wish you all the very best as you move forward in the future. This is very exciting.
Mark, thank you to you and the team for having us today. I know it's a pleasure for us to get to meet our partners across the street, and they'll hopefully see some collaborative follow-ups as well.
Yes, and possibly beverages. So anyway, thank you all very, very much. This has been absolutely wonderful. And so this concludes the session of our day today. Thank you all very much.
Thank you.